Tonight, I look at this as a double discussion. What do I mean? We're going to talk about procedures that we do in the OBGYN's office, and also some procedures, some surgeries that we do in the hospital, in view of with the halachic implications. But one of the things that has come across my desk over the course of years is a number of Rabbanim have called me for clarity in exactly what these procedures are. So we're going to talk a little bit in depth. Portion number one is what the procedure actually is. And I spent my day a couple of days ago going through my office and bringing home relevant instruments. So I'm going to show you what they look like. I have a couple of models also for clarity's sake. And then, of course, the major portion of tonight will be looked at the halachic implications of the different procedures that we do. With that said, I think that we should start off, and I'll ask you, Rabbi Segelman, for a basic primer in our context of the difference between Dam Niddah and Dam Maka in light of OBGYN procedures.
Good. Okay. Thank you very much, Dr. Herman, and thank you everyone for joining us. When we come to this sugya, this question of gynecological procedures in Hilchos Niddah, so really there are two very important points that have to be addressed. Number one is what Dr. Herman just said, and that is the difference between Dam Niddah and Dam Maka. That's number one, and that really boils down to identifying the source of the blood and recognizing that when we speak about Dam Niddah, that doesn't mean that all blood that comes from the vaginal area is Niddah blood, but it's very specifically uterine blood. And even with that, even within the world of uterine blood, there is a major machlokes about blood that comes from the uterus as a response to some type of trauma. And if a woman has menstrual bleeding and the endometrial lining, it detaches and leaves the body, that everyone agrees is Dam Niddah. However, if you take a knife or an instrument and you poke the uterine lining, causing the uterine lining to bleed, not everyone agrees that that's Dam Niddah, even though its source is the uterus. But since the reason for that bleeding was because of some type of trauma, instrumental trauma, so therefore that would, according to many poskim, would not render a woman a niddah. So the first thing that we always have to recognize and to identify is the source of the blood, whether it's coming from a cut, whether it's coming from a natural part of a woman's menstrual cycle, or whether it's even hormonally manipulated. We'll talk about that later on, Mirz Hashem. But also when it comes to gynecological procedures, there's a whole nother sugya, a whole nother halacha that has to be addressed. And that is the halacha of what the Gemara calls I efshar lepsichas hakever below dam. It is impossible for the uterus to open without blood, which the Gemara has a discussion. The Gemara Niddah has a discussion where a woman miscarries, or a woman actually has, it's not even a miscarriage, some foreign item, some foreign object is expelled from the woman's body, some chaticha, some piece of skin or whatever it may be. And the Gemara goes back and forth whether there is blood, whether there's no blood. And the Gemara, there has a machlokes there and says even in a case where there's no blood, it's possible for that woman to be a niddah. How so? How could a woman be a niddah after either giving birth or expelling some type of object from the uterus out the vagina? How could a woman be a niddah if there's no blood? The Gemara tells us the halachic principle that I efshar lepsichas hakever below dam, it's impossible for the uterus to open without some blood coming out. And the fact that we don't see blood here in front of us doesn't mean that blood didn't leave. And therefore, we're obligated sometimes to assume that blood was present, obligating us to render the woman a niddah, despite the fact that we don't actually have any blood at all. So the question that really was going to boil down to a very practical one, an extremely practical one, and it may even differ from different doctor to different doctor, different office to office, is that when an instrument is inserted into the vagina, into the cervix more specifically, how big, what are the measurements of that instrument? Are we obligated to say EF shalapsichas hakever below dam? So I don't know if you want me to get into specifics now. Maybe I'll get into a few specifics to introduce the topic, and then I'll throw it back to you with some practical examples. Insofar as since we're now on the topic of EF shalapsichas hakever below dam, there's a very 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 large sugya with many Rishonim and Achronim about this idea. There's a famous Nodi Yehuda who raises the idea that the Gemara was talking about something that was expelled from inside the body out. Do we even apply the same concept from outside the body in? Here we're inserting an instrument from outside internally, as opposed to the case of the Gemara where the item began inside and it was pushed out. We generally assume, although this is debated, we generally assume that it doesn't matter whether something is coming out or something is coming in. If the cervix is opened to a certain measurement, then we'll say EF shalapsichas hakever below dam. What is that measurement? Also a huge machlokes. Thankfully, we're in America. Not thankfully we're in America, but thankfully we should be in Eretz Yisrael. But thankfully we had in America a Gadol Hador whose yahrzeit was just this past Tainus Esther, Rav Moshe Feinstein. Rav Moshe Feinstein was the Rashka Bahag, the Gadol of America, and Rav Moshe paskined very clearly when it comes to this sugya of EF shalapsichas hakever below dam. Rav Moshe paskined 3/4 of an inch is the shear, which equals 19 millimeters. 19 millimeters, just under 2 centimeters, is the amount of the width of an instrument that up until that point will not render a woman a niddah. If something is inserted and it is over 19 millimeters, so then we would assume that the woman is a niddah because of EF shalapsichas hakever below dam. Under 19 millimeters is not a problem. That's what we call dak shebedakim, something which is so thin. And Dr. Herman, I'm sure, will tell us all of the different tools that he uses, instruments that he uses, and their measurements. But that is not everyone agrees to this, but that is the psak of Rabbi Moshe Feinstein. And I believe that's the accepted psak in America. So insofar as the psichas hakever question is concerned, we always have to ask the doctor, well, if something is being inserted into the cervix, how far into the cervix? And even if it's going completely into the cervix, into the uterine cavity, what are the measurements of this instrument that you're using? Furthermore, let's say you're going into the uterus, let's say it's under 19 millimeters, but as we said before, even if there is blood, we always have to identify the source of that blood. And as I mentioned earlier, this machlokes between many of the Achronim versus the Chazon Ish and others who hold that even uterine blood from a trauma is not called dam niddah. Many poskim lahalacha do go with that. So even if the doctor had to take a little scrape of the uterine lining, causing some blood as a response or as a result of the uterine scratch, as long as that's not going to be a flow and it's just going to be some spotting, so very often that won't necessarily render a woman a niddah. But let's talk about each case, and we can get to the halacha, specifically, get case specific. But again, the background that's necessary that we have to understand before we get to talking about the various gynecological procedures, twofold: psichas hakever in terms of the instrument, the size of the instrument, and the source of the blood. Anything which is not uterine, anything which is vaginal, cervical, or anything of that sort is not even a question. It's not even a question. It's certainly not dam niddah, as the only time dam niddah can even be a question is whether the dam comes from the uterus. And even then, as I mentioned, there's a machlokas.
Awesome. Well, my first comment is that there's almost no instrument. There is no instrument that I use in my office that's greater than 19 millimeters.
Yep.
And throughout my career, I've had, again, shaila after shaila, after seeing patients where I would have to find out and actually sometimes I even go through the garbage to figure out with my disposable instruments what the size is, but it doesn't even come close to 19 millimeters, as you will see.
I guess the question could be, maybe we'll get there. Maybe let's jot it down to talk about a balloon to see if the balloon would dilate the cervix more than that. But let's talk about that whenever.
Right. Okay, so starting off, what's the most common procedure, most common thing that I do in my office? Well, it's a pelvic exam. Now, a patient comes for a yearly checkup, and I do a bimanual exam with one glove, 2 fingers into the vagina and pressing on the belly. I feel the cervix, the uterus, sometimes the ovaries, and it wouldn't be uncommon for me to take my glove out after I'm done and see that there's some spotting or bleeding on it. In no way do I feel that's uterine blood. It's blood from irritation from my exam. What is a patient, so that would not render her a Niddah, correct?
Assuming that you were poking around in there and you knew that as the area is very sensitive, so you knew that it's very understandable that the blood is coming from a makkah, especially if, especially where also there's a little bit of of a difference between whether the woman is coming in as a Niddah, and the question is, are we obligating her to restart her 7 clean days, or is she already coming in with a chezkas tahara? She went to the mikvah, she's already established for herself a chazaka that she's not a Niddah. But yeah, it's very reasonable that after the doctor does an internal exam and he knows based on his experience in this woman that this area is very sensitive and there's bleeding, so I think that that's reasonable. You can assume that it's dam makkah.
Okay, so what does happen when during the time where she is counting clean days, right? And I examine her and we see blood at that time. What does she do that day with counting and so on?
Yeah. So whenever a woman goes to the doctor, whenever a woman goes to the gynecologist, during the 7 clean days, I always tell them the same thing, that it's critical that a bedika should be done before the exam. Before you go, let's say your appointment's at 9 o'clock, before you leave the house, do your bedika for the day. And that way your bedika is in the clear. Then you go to the doctor. Now it's possible that you'll see some blood from the appointment. We assume, as we established already, that blood can be dam makkah. So that dam makkah is not going to compromise her shiva nekiyim, right? It's not going to make her start over. But if she were to, it may complicate things a little bit. And that's why she should not do the bedika, not do a bedika in the afternoon. And depending on where she is in her cycle, maybe hold off a few days of bedikas. If she's going on day 2 or day 3 of her shiva nekiyim, maybe hold off for a few days until allow the area to heal and then resume bedikas towards the end of shiva nekiyim. But assuming it's dam makkah, it will not require her to start over.
Right. So just as an example, it wouldn't be, again, uncommon for someone to come in and for a yearly checkup and say, quote unquote, you're not going to make me a Niddah with your exam. So patients do have that concern, although again, the pelvic exam cannot make them a Niddah because it doesn't fulfill any criteria. Number 2 on our list is a transvaginal ultrasound. I do hear every once in a while, I was told to ask you, does the probe enter the womb? And the answer is absolutely not. It does not. It's a vaginal ultrasound. It can touch the cervix, but will not go into the cervix or into the womb. So our conversation basically would remain the same in regard to a transvaginal ultrasound as it would a pelvic exam.
Yeah, a lot of what we're going to discuss, I imagine, is going to be the same. It's going to fall into the same categories, that a lot of these things go into the vaginal canal, may touch the cervix. Sometimes they'll penetrate the cervix slightly, but once we're not going into the cervix or into the uterus, it really it's hard for these gynecological procedures to actually render a woman a Niddah.
So that's going to be our first 4 topics that we talk about: pelvic exam, transvaginal ultrasound, and the next one is going to be the pap smear. Now, for a pap smear, first I'll just tell you, I get very nice gifts for Hanukkah from my family, from my nephews and nieces, and I'm about to show you one for demonstration purposes. Okay, and although people find it very funny, and I do as well, tonight it's actually a good prop. So here is Hanukkah gift from a few years ago. It has a name. It's called IV the uterus. But what's important about this is to show you this is the cervix, the entrance to the womb, right? The entrance to the uterus. And as we follow it up, we see the fallopian tube and the ovaries. And we're going to refer back to a number of things. With a pap smear, and this is a pap smear brush, goes into the vagina, right? We have a speculum that we put in. It opens up, right? So we could see in. The brush goes through there to the cervix. And if you could see the shape of it, the very tip goes into the cervical canal, collects some cells by rotating it back and forth, and this collects some cells from the outside of the cervix. It does not go all the way up the cervix. It goes to like there, but in, right? So it doesn't make it all the way up the cervix into the uterus. Frequently causes bleeding. I tell the patients to expect it, but I also tell them in no way could a pap smear make them a Niddah.
I agree with that.
The next of the four, pelvic exam, transvaginal, ultrasound, pap smear, is a cervical polyp removal. Okay, not uncommon. Do we see in the tip of the cervix, you could see a polyp. I explain that to the patient as a piece of tissue, like inside your cheek that you're trying to get off, that you feel inside your cheek, and you take your fingernail and you scrape it off. A piece of tissue that's hanging off. And we see sometimes at the tip of the cervix or in the cervical canal, we see that, we grasp it, and actually sometimes twirl it, and it'll come off pretty easily, and the patient will get spotting and bleeding for a couple of days. Again, that resides in the cervix and does not go into the uterus, right? Cervix, uterus. Again, would fall into that same category as 1, 2, 3, and 4 that we've been talking about.
Right.
Today, just to go back to pap smear, I had a patient come into the office today, and she was planning on going to the mikveh tonight, right? And she really wouldn't know what to do if she began staining after her pap smear, knowing that she's going to the mikveh tonight. So maybe you could comment on that for a second, what she should do.
Okay, I'll comment on it, and I'll also address one of the questions that was put in the chat, and that was, what if she has a stain on her undergarment bigger than the size of a penny? So really the answer to that question and the question to Dr. Herman is the same, that any blood that she sees either immediately after the pap smear or whatever it is, whether she finds it on the bed or she finds it in her underwear, those are all blood that we can disregard because we know that it came from a makkah, right? In general, the halacha of staining and blood found on underwear, even white underwear, larger than a penny, one of the leniencies that Chazal allowed us to exercise is if we have a tliya, if we can attribute the blood from some other source, right? Some source other than your period blood. So then, or dam niddah, then you're allowed to assume that the blood came from there. This is a perfect example of a tliya, of an instance where we're able to say this blood is not coming from the uterus, this blood is coming from the pap smear, it's coming from the ultrasound, whatever it is. And therefore, even if the blood is on white underwear and the blood is more than a penny, nevertheless, it will not cause you to start over the Shiva Nakim. You can ignore it. Now, not only can you ignore it on your underwear, you could theoretically ignore it altogether. And she can go to the mikvah and have relations. And the truth is, even if she sees blood after relations, if she spoke to the doctor, she knows for sure that the blood is coming from as a result of the pap smear. So that blood will not render her a niddah because, again, it's not dam niddah, it's dam makkah. I will remind us that in such a situation, when you're going to have a pap smear on day 7, it really behooves you to do that bedika in the morning and not, before your exam and not after, because if you do it after, so then you're going to have a little bit of an issue. And the reason why you're going to have a little bit of an issue is even though you know the blood is coming from a makkah, but if you do a bedika and there's dam makkah on the bedika cloth, so knowing that it's a makkah, here's a little bit of a lumdisha point, knowing that it's a makkah won't require you to start over. It won't invalidate the bedika, but it also won't count as a clean bedika. The heter of a makkah will say, okay, this bedika doesn't invalidate your count, but it's hard to say that not only is there blood on the bedika cloth, but since we know there's a makkah, we could call this a clean bedika. That's a little bit harder to say, and therefore I urge everyone to be very, very, mindful of their Shiva Nekiyim and their gynecological exams, and to always do those bedikas before the exam. What would happen if a woman forgot? So then, different poskim say different things. Either she has to wait another day, or maybe even go that night, knowing that she had bedikas earlier. That's a different machlokas, different shear. Can you go to the mikvah on day 7 without a day 7 bedika?
Okay. We're going to move to another category now, because now we're going to go past the cervix and into the uterus. An IUD insertion. IUD, an intrauterine device. And I'm going to show you just a little model. I don't know if you can see it well. This is a model of the uterus. Inside, you could see a T. This is a copper IUD with the strings that will be cut short once it's in place and reside in the vagina. So the vagina is down here, and you could see the copper IUD in the uterus. Now, how does that get in the uterus? That gets in the uterus, and we start again with the speculum to look into the vagina. We get the cervix in our view. Okay, we get our cervix in our view. Often we have an instrument called a tenaculum that will hold the top of the cervix with, right, to hold it in place. And then we have an inserter, and you could see an IUD at the top of the inserter. We'll introduce that into the uterus as a straw, like a straw. Let me just show that to you. So the IUD is in the straw, and then when it's inside the uterus properly placed, we push it out and open, and it remains there, and we pull our inserter away, leaving the IUD behind. One of the things that we do before we put in that IUD is I call it my measuring stick, right? That goes in through the cervix to the top of the uterus, so I know the depth where I'm placing it. I happen to put in all IUDs under ultrasound guide to make sure that they go in the right place. So our inserter is about 4.8 millimeters. Okay, that's 4.8 millimeters.
Remember, the lucky number is 19, so it's significantly smaller than 19 millimeters.
It's smaller than that. Okay, so that's how we do an IUD insertion. Now, the tenaculum, again, is not pretty, holds onto the anterior tip of the cervix, the top of the cervix. So when we put in the IUD, it doesn't just push everything away. We got to go up the canal. Okay, when I take that off, that commonly bleeds, right? And I put pressure on it until it stops bleeding. And most of the bleeding I'm going to get is going to be from that, which is from the tip of the cervix. And I specifically look to see, did any bleeding come out from me introducing my instruments back and forth? So that's basically what an IUD insertion is.
From a halachic standpoint, based on your presentation and based on Rabbi Moshe Feinstein's psak, his ruling, and the insertion of an IUD would not render a woman a niddah, because the insertion, the instrument that's inserting the IUD is 4, maybe 5 millimeters, but significantly less than 19 millimeters. The tenaculum is not penetrating, you're not opening the cervix more than that. I personally, according to Rabbi Moshe, do not see any issue niddah-wise with the insertion of an IUD. I am familiar with other psakim, with other rabbanim who disagree and who hold that the insertion of an IUD renders a woman a niddah. However, I don't know how that shita is justified with Rav Moshe's psak. So if someone wants to go more machmer than Rav Moshe, then certainly the insertion of the IUD can be a niddah shaila. But if you go with Rav Moshe's approach, I do not find that the insertion, and maybe we could talk about the removal while we're at it, of the IUD is going to render a woman a Niddah.
Okay, so it's now 5 days after I put the IUD in, and the patient calls and says, I'm bleeding. Now, just to preface that, it is very common to bleed for 1 month after putting in an IUD. So at what point does the bleeding from the application turn over to the bleeding from the IUD? Or it doesn't? Is she good the whole month or not good the whole month? So let me tell you what I've heard from my patients is that about 60% of Rabbanim tell my patients that the application of an IUD will make them a Niddah, and that they should put it in while they are a Niddah already. And about 40%, and these are just my impression, I didn't take a poll, 40% of Rabbanim say, listen, go and have it put in when you're already back from the mikveh, because all that bleeding is not Niddah blood. So I see a very big disparity in what the Rabbanim are telling my patients.
Again, I was referring to the actual insertion. Let's assume there's no blood. I'm talking about the insertion itself. Right. Insofar as the psichas hakever question is concerned, I personally don't find that there should be any, according to Rabbi Moshe, I do not think that there's any reason that a woman would be a Niddah upon insertion because of the insertion. Now, what happens next is a different story. The bleeding that happens next, that's something else. The bleeding that, any of the bleeding that happens immediately after, and if it's just spotting, then we would attribute it to the insertion. The insertion, the uterus there was some uterine trauma.
In the tenaculum, I see it bleeding. I know that there's going to be something residual from that.
Right.
That's for sure.
I think everyone can agree. The question is, let's say the bleeding becomes more consistent, and let's say it becomes heavier. So then we come into a huge machlokes, which is really beyond the scope of tonight. And that really boils down to the difference between the hormonal versus the non-hormonal. The hormonal IUD, generally speaking, the poskim are more machmer, and there's more room for leniency potentially when it comes to the non-hormonal IUD. There was an amazing study in Eretz Yisrael, in Baylor, maybe it was Baylor. Well, one of the hospitals, a Rav and a doctor is doing their doctorate on this question, the difference between the hormonal and the non-hormonal. And they took ultrasound pictures and images from two different uteruses, one with the hormonal and one with the non-hormonal, to see how the uterus develops and how it responds to the IUD. And they saw that the bleeding from the hormonal IUD was in a complete a complete and total uterine response, meaning the entire uterus was swelling up and the entire uterus was bleeding and participating in the source of blood, as opposed to the non-hormonal, where the bleeding was very local. It was around the area that the arms of the IUD were, and the thesis is that the bleeding from the hormonal IUD would be considered dam niddah, but the bleeding from a non-hormonal could be considered dam maka, is that uterine trauma. On a practical level, most rabbanim are not comfortable making this differentiation, this distinction. Most rabbanim hold both for the hormonal and the non-hormonal. If the bleeding becomes like a flow, then it's niddah. I've spoken with Rav David Cohen from Flatbush many, many times about this, and Rav David is confident and willing to publicly say that the bleeding from the non-hormonal IUD, only non-hormonal, can be considered dam maka, I once had him speak for Rabbanim on a Zoom session. It was an interview. I was interviewing him, asking him shaylas on Hilchos Niddah, and the other Rabbanim were on the call, but they were listening. They couldn't chime in. It was like a webinar, and I asked him about this question, and he was confident. He was mekel. Afterwards, Rabbanim started emailing me. How could he say this? How could he say this? And one Rav wrote a tshuva against what he said. So I called up Rav David and I said, Rav David, I just want to let you know what's happening. The Rabbanim that were on the call, some of them were very upset with this psak. So first he said, you think I make up my own psakim? You think I make up my own science? When the Shaila came to me, I asked my doctors, my OBGYNs that I'm close with. That was the psak that I came up with. But let me ask them again. Give me a few days. He calls me back a few days later. He said, I spoke to my doctors. I do not retract even one word, and I'm willing to write a tshuva against that Rav, and I hold my ground. So Rav David is pretty confident to say that the bleeding from the non-hormonal IUD can be considered damaka, whereas the hormonal, he doesn't comment on it. He's too nervous. He doesn't understand. He says that it's too difficult to rule out a non-niddah option. But the bleeding from an IUD is a major shaila. But again, our initial question was the insertion. I was just commenting on the insertion. I am aware that people say the insertion makes them a niddah, but according to Rav Moshe, it should not.
Okay, so again, just focusing for a second on this disparity that I get with the patients who are coming in, who are saying their Rav says that it is dam niddah. There's a group there certainly seems to be a group of Rabbanim who hold that way.
The only thing the most beautiful relationship is between a Rebbe and a Talmud, between a Rav and a constituent, a member, whatever it is. And I do not want to come in the middle of that. If your Rav holds this way, we respect what Rabbanim say. The only question I think that Dr. Herman might be able to, probe a little bit is, does your Rav not hold like Rav Moshe? If the answer is, yeah, my Rav holds like Rav Vosner. Okay, so if your Rav holds like Rav Vosner and the shear is much smaller than 19 millimeters, so now we understand why they're machmer with the, with the insertion of the IUD. But if they go back and the Rav says, no, I hold like Rav Moshe, so then maybe there's some type of misunderstanding in terms of what the insertion of the IUD is, and maybe it's a good idea to inform them, because if you hold like Rav Moshe, unless I'm missing something, if you hold like Rav Moshe, it shouldn't render a woman a niddah.
Okay. The next thing we're going to talk about is IUD removal. So in 90+% of the cases, after the patient calls and would like an IUD removed, I put a speculum in the vagina. I see the strings sticking out the end of the cervix, and I just grasp onto them and I pull them out and the IUD comes out. Very straightforward. But every once in a while, I have a patient who comes in and we can't see those strings. So we try with a Q-tip first, and second I take a little brush and I put it into the canal of the cervix and I try to tease out and see if that string will become visible. And every once in a while, it doesn't become visible. And there's no way for me to take out that IUD. With that, I have a special instrument called an IUD hook. And I introduce this into the uterus. I go up the canal and into the uterus, all the way up to the top. And with those little grooves, I press against the wall and I pull down. And a lot of times this will grasp onto the IUD arm or the shaft, and it will pull it down well enough for us to find it. Now, I didn't look at 100 people that way, but certainly I would expect them to have bleeding, and that bleeding we know is coming from the uterus. And I know that I am the one who had just caused that bleeding. Okay, so now I have a patient who has bleeding. I removed her, let's say, hormonal IUD, right? I removed her hormonal IUD. The bleeding I caused is going to go on for 2 or 3 days. But also, guess what? I just took out her hormonal IUD. So eventually she's going to get bleeding because I removed her IUD. And they're going to cross over one into the other. So at what point does she become a niddah?
Well, what's the size of that instrument? It looks small, but...
Certainly it's nowhere 19. Okay, just to give clarity, this is a dilator. And if you see this is 10. The width of this is 10 millimeters. Okay, and here's the instrument that I'm talking about, which is very much half the width.
Yeah. So you're asking a great question. Again, going with Rav Moshe's approach, the actual removal of the IUD is not a problem, right? The blood that we see from the removal of the IUD is dam maka. There could be, according to the Machmirim, who holds that any blood that comes from the uterus, even if it's traumatic, is a niddah, right? Any blood that comes from the uterus. So maybe according to them, that it might be a little bit of a shiloh, but still, according to almost everyone, especially if they don't have a flow, the actual removal is not going to render them a niddah. The question then becomes the hormonal response, the withdrawal of the hormonal IUD. That really, the way I would what I would recommend is as follows. A woman should be wearing a liner, panty liner, pad of some sort, which I think in previous shiurim, I believe we discussed, is not makabel tumah. So if it's not makabel tumah, the fact that we see a penny's worth of blood is not going to automatically render her a niddah. She should wear the liner, and even if it's white, again, it's not makabel tumah, so it's not going to make her a niddah. But she should frequently inspect it and see at what point does the bleeding get heavier. Some bleeding is just going to be trauma blood, and that will likely get smaller and smaller and diminish as the time goes on and the wound heals. However, once she starts to see an increase in blood, and once she starts to see that it becomes heavier and more like a flow, so then at that point she has to question, have we reached the point of a flow? Have we reached the point of a period? Or can we still say that this is in the realm of spotting? And that is a very blurry and a very difficult line to draw. When do you go from spotting into a flow? And different Rabbanim say different things. I don't remember if we've spoken about this in the past, but some Rabbanim say like a $50 bill. If you have a $50 bill's worth of blood, already that's beyond the shear, like a period. A $100 bill, that's not a problem. Credit card, something along those lines. Other Rabbanim don't even use those shear. I don't believe uses shear. He says it. You have to look at the pad, look at the and see how the blood lies, and see how it mimics your period.
You become very choppy. It's hard to hear you now.
Okay, hold on. Better?
Much better. So
Yes.
I think if a woman is alert to that, they will see the decrease and then an increase again. I think they really can identify the dichotomy between the two.
Yeah.
Hysteroscopy, which is number 6 on our list. There is now an instrument called an endoscopy, where in the office we could look inside the uterus. The instrument is 3 millimeters, 19 millimeters, that could be introduced. It's attached to a camera, a little screen, and we could see what's going on inside. Again, that would easily fall into what we were talking about. Just to mention 2 more procedures that we do that we can or do in the office. There's a procedure that we do for an abnormal pap smear. When it's reached a certain level, we do a LEEP procedure or a cone biopsy, where the area of interest is the cervix. Excuse me for a second. Actually is the hospital, but my partner will answer that. Is the tip of the cervix, where we take a cone of a slice of tissue from this area. It will cause bleeding, but again, it is nowhere near the uterus and should be not even questioned as far as Niddah goes. And finally, a procedure that I won't do in the office, but that we need to do from time to time is the hymenectomy. And that's a procedure that I really would like to discuss with you because it has so many implications for my patients. And the patient that I'm talking about is a kala. And I have situations where it's identified that they need that done before they get married. And I've had numerous newly married couples come in who need it done. Okay. The entrance to the vagina has a ring of tissue, the hymen that goes around. One of common things from birth is to have some tissue coming across. There's a little opening, but the hole is blocked, or the entry is blocked, and that tissue needs to be taken away in order for them to have relations. I've had patients who we've identified that recently a year before they got engaged, before they got married, and I took out the tissue then. And I've had patients who have been married already and they couldn't have relations, so they came in and we've taken it at that point. So my first question to you is, when I remove that tissue, what implication does that have for the kala, for her wedding itself? When we talk about psulim at the wedding, and then after, when they have relations the first time, and they don't get bleeding because the hymenal ring is no longer there.
Okay. Let's just focus on a case. Let's focus on the case where the chassan and kala had difficulty consummating the marriage. They had a difficulty with intercourse, and when they present to the doctor examines them and sees, of course, you're having issues with intimacy. You need a hymenectomy. The hymen is just too thick, whatever it may be. Right. Here, Rav Moshe Feinstein has a tshuva where he says very, very beautifully, it's a big chiddush, but a beautiful chiddush, that the nature of Niddah immediately following the breaking of the Besulim is a very interesting one, and it is one which was limited to a very specific scenario, namely when a chassan and kala, when a bride and groom have relations for the first time, or when relations causes bleeding due to the hymenal bleeding, as opposed to a physician with doctor tools removing the hymen. Anytime it becomes a clinical process and not an intimate one through tashmish, through actual intercourse, Rav Moshe says that is not the type of bleeding that Chazal instituted to render a woman a niddah following her wedding. And therefore, should the couple be intimate and that intimacy cause bleeding from the hymen, that would absolutely be a niddah. The woman would be a niddah, dam besulim. That's not a question. However, if the doctor removes the besulim, or the doctor causes bleeding from the besulim outside of the world of intimacy, but in the doctor's office, Rav Moshe writes that bleeding is not a problem at all. It goes back to our original point that is dam maka. Because if you think about it, all hymenal bleeding should be dam maka. We already established in the very introduction to this session that the only bleeding that could render you a niddah is uterine blood. So the fact that the hymen is bleeding and rendering a woman a niddah is, to begin with, a tremendous chiddush. That's why Rav Moshe understands that chiddush was a special case in Chazal, limiting it to the bedroom. Once the bleeding takes place in the doctor's office, you do not become a niddah. And therefore, should a couple require a hymenectomy to allow her normal intimacy, that a woman can do it in the middle of her 7 clean days, and it will not compromise the 7 clean days. A woman can do it when she's not a niddah, and it will not cause her to be a niddah, all according to Rav Moshe Feinstein.
I had one time a patient who had got married, had relations, had a lot of bleeding from having relations, became a niddah, and then the Rav called me and said, "What is the chance she's going to bleed next time she has relations? When she goes to the mikveh, comes back from the mikveh, what's the chance that she's going to have bleeding again from the same area?" And I found that curious because I never heard that would render her a niddah after the first time they had relations.
Shulchan Aruch says clearly that a woman will be a niddah every single time, after, even after the first time, the second time, the third time. What she needs, it's an interesting thing because there is a halacha, and I don't want to scare anyone here. I'll say it, I'll preface, I've never ever come in contact with this halacha l'maisa. I've never experienced halacha l'maisa, and I've asked many seasoned rabbanim, and they also have never really come into contact with this on a halacha l'maisa level. But the Gemara does say, and it's mentioned in Shulchan Aruch Kuf Pei Zayin in Yeridea, that if a woman bleeds 3 times consecutively after Tashmish, the halacha is they have to get divorced. That's a halacha, and it's a Gemara, it's a Shulchan Aruch. So seeing blood after Tashmish can be a very scary thing. Now it's clear that Bisulim, hymenal bleeding, does not fall into that category. So the Shulchan Aruch says that a woman can continually be of Niddah every single time. The second time after the mikvah, then she goes to the mikvah the 3rd time, the 4th time. It'll never end. But it will never enter that parsha of Roya Dam Machmas Tashmish that would require them to potentially get divorced. There needs to be a break in the bleeding, they'll have Tashmish, they'll have intimacy without any blood, then the clock starts. The Roya Dam Machmas Tashmish. But what's clear is that they can have intimacy, they can have Tashmish and relations for 2 or 3 or 4 times, 4 cycles. We're talking because she's going to become a Niddah immediately after Tashmish. So 4 times going back to the mikvah again and again and again, that will render her a Niddah, absolutely.
Absolutely. Okay, so let's go back to the other case where we figure out a year before they get engaged that there's a problem. They try to put in a tampon, it won't go in, so they come to the doctor. We see that there's extra tissue coming across, and now we've taken that tissue out. Okay, and we get questions like, "Oh, you've affected her basulim. What happens at the wedding with a ksuba, all that stuff that goes with that?" So I'd ask you for your comments on that.
I've been involved in these cases. I've been involved in a number of these cases, and they're often not pretty, unfortunately.
They've also asked me, how much of the hymenal ring have you taken out?
Yeah, so that's a good point. Most of the time, unless a doctor, let me put it like this, unless the doctor says, I solemnly swear, I can tell you 100% unequivocally that I've removed every single last particle and piece of the hymen, there's absolutely no hymen. So then we would enter a case where a woman would literally be hymenless, okay? She would be, and when they would have tashmish after the wedding, she would not be a Niddah. She would not be a Niddah following the relations that they have after the wedding. The question is it appropriate to do it before the wedding? Is it necessary? And then if it's done, must you inform the other party? I was involved in a case not too long ago where a woman felt that she needed to do this. She had some type of internal before the wedding, and the doctor saw something strange. I forget exactly what it was. Septum, maybe it was a septum. And I think that's what it was. And the doctor fixed it and removed all the basulim. From doctor, removed all the basulim, and they didn't tell the chassan until the middle of the engagement. And when the chassan found out that he was marrying, he was about to marry someone who didn't have a hymen, he was incensed. He was so upset. He came to, and they were talking about calling off the shidduch. I mean, this was, right. They were livid. They were so upset. But everything is fine. It blew over. But they were just so upset that that the other party withheld this information. They felt this was very significant. On a practical level, it was actually interesting because the Kala, the advice that she got from the Kala teacher was that this is an amazing opportunity for you. You get to go to your wedding, and you never have to worry about that, annoying and inconvenient and burdensome Niddah window immediately following the wedding. He was coming from a totally different perspective, a totally different hashkafa. This is the way HaKadosh Baruch Hu set up the world. This is not, it's not a punishment. HaKadosh Baruch Hu didn't want to punish every chassan and kala immediately following their wedding. But this is on the contrary. This is the way HaKadosh Baruch Hu set it up, and this is what I want to do. Now, there are exceptions. There are certain exceptions where women, they're born, they don't have a hymen. They lost their hymen when they were doing gymnastics, when they were riding their bike, when they were doing something. Okay, that's an exception. But to manipulate and to manually remove the basulim and take yourself out of the natural course of what HaKadosh Baruch Hu said in play, they were so upset. That's why it's a sensitive topic. In a case where a woman has to do it, if a woman needs to do it for a medical reason, I think many of the poskim do allow for the hymenectomy to take place. The question is, once she nears shidduchim, mentioning this to the chassin on the sooner side rather than later might be helpful. But also, as a final point, it's really not so relevant because nowadays, in terms of the actual ksuba, Rav Moshe Feinstein has a psak where he says that really the difference between a ksuba of a virgin versus a non-virgin is just 100 zuz. It's just 2 mana, right? 100 mana versus another mana. So if the chassin accepts upon himself the full ksuba, the more expensive option, and he accepts upon himself, and he doesn't have to tell anyone, the Mesader Kiddushin doesn't have to know. The chassin knows that I'm accepting upon myself a financial responsibility of 200. So then even if she's a mukas eitz, even if she's not a virgin, even if she had relations before, Rav Moshe, not everyone agrees, but Rav Moshe writes you can even write besula in the ksuba and nothing changes because as far as besula is concerned, it's just a monetary value which the chassid is being makabel upon himself.
Great. Now, I have to tell you, I can't even imagine anybody removing all of the hymenal ring. Even in the most difficult cases that I've ever seen, I've removed the tissue from looking at a clock face from 3 o'clock to 9 o'clock and leaving all the tissue above. And the reason that I leave that tissue above is we've corrected the problem, 1, and 2, that tissue above could lead to scarring, which could be a big problem. So I've been able to fix every single case that has presented by just removing that tissue and no more. So I've never, ever had a case where all the tissue has been removed.
And when a couple have normal relations and they come, let's say 6 months after the wedding, and you examine the vagina and the vaginal canal 6 months post, is there residual? What are they? How common is it that there would be a residual ring around the most outer layer?
Again, it's not a residual ring. It's from 9 o'clock back to 3 o'clock. That tissue remains there. And we still see that tissue after someone gives birth 7 times and babies come through. That tissue we could still identify. And when a patient has the baby makes a cut coming out or has an episiotomy, that's our landmark. We put that tissue back together so we know what goes to what. So I've never heard of a case of the entire tissue being removed.
Good to know, yeah.
So that really ends our discussion about what happens in the office. And I'm just going to turn quickly to the cases that we do in the operating room. There's a couple of, I'm going to mention a few of them, and there are a couple of halachic questions that we have about them. The first one, there's really no real question, called a cervical cerclage. When we have a patient who has a cervix that's not holding their kids, they miscarry because they have cervical insufficiency. Often we'll bring them to the operating room when they are pregnant and put a stitch in that's in the cervix itself at the very top of the cervix and put 2 stitches in that way. And there's no real discussion, even though they will have bleeding for the next few days after that. It falls under no criteria of Niddah as far as I could see. The next procedure that we do more often that does present a problem is endometrial ablation. Now, endometrial ablation I love that procedure because it saves patients hysterectomies. We use it for a patient who keeps bleeding and bleeding and bleeding and is basically has told us that they are done with childbirth, because we won't do it in a patient who still wants children. I introduce a instrument through the cervix, 7.2 millimeters. I looked it up. And it opens up inside the uterus, opens up inside and cauterizes the whole inside of the womb as much as we can. I tell the patients it's like someone who has a nosebleed and goes to the emergency room and they cauterize the bleeding inside the nose. Here, what we're doing is going through the cervix into the uterus and burning, cauterizing the inside, telling them this is not birth control, but the idea is to destroy the whole inside of the lining. And 20% of the time, they never get any bleeding again. 80% of the time, in general, they'll get reduced bleeding compared to previous. Is there any halachic issue in intentionally destroying the inside of the uterus? Basically, it's sort of not guaranteed, but you're trying to achieve where they can't get pregnant anymore, even though they're still of childbearing age, but have no desire to have more children. So I want to query you about that.
This is a question of serous. This is a question of whether it is permissible to sterilize and to do something to what the Gemara calls the clay leda, the reproductive organs. Are we able to be misaris a woman? That's the question.
Even though it doesn't 100% do that, but that's sort of your intention. That's what you want to happen in these cases.
Yeah, understood. I asked this shaila to Rabbi Shmuel first a number of years ago. Rabbi Shmuel, I think he told me that he consulted with Rabbi Yashiv, and Rabbi Yashiv said that since it's possible for the woman to become pregnant, even though it's unlikely, since it's possible, that's not called serous, and therefore, insofar as serous is concerned, it is not an isser. It's not a problem. My question about the ablation is, if a woman does get pregnant, can she maintain and sustain a healthy pregnancy, or what's the medical approach to that pregnancy?
So there have been pregnancies to fruition, but in general, if the implantation is going to a place that has been, damaged and destroyed, there's a much higher chance that she'll miscarry.
Is there any health concern to the woman, or it just would be like a standard miscarriage?
Miscarriage is more of the risk than anything else.
Yeah, that's very understandable. In terms of serous, again, the answer that I got from Rabbi Shmuel first a number of years ago from Rabbi Yashiv was that it's mutter. That in a case where it's necessary, like you had described, then it's mutter, and it's not a problem of serous.
Moving to the next procedure that we do commonly is a laparoscopy. Just to describe what that is, it's called minimally invasive surgery. In years past, where we used to make big cuts on the belly, on the abdomen, now what we do is we make a tiny cut by the belly button and introduce a scope through there, and cuts a little bit lower down where we put instruments in, and we're able to operate through there. And treat and remove different tissues. And instead of the patient being laid up for days and days, now we could do surgeries, remove, in fact, the entire uterus, and the patient goes home the same day with much faster recuperation. That was just to tell you what the procedure is. One of the things that we do in a laparoscopy is a patient will say, I would like a tubal ligation, and we will go through that. Put the instruments in, and we will cauterize the tubes, damaging and destroying the tubes, which brings us back under what circumstances is a frum woman allowed to have a tubal ligation?
Okay. This is, again, these are serious shilas.
This is serious an introduction. We're not just an introduction to
serious shilas. The 1 minute answer to this question, although it's a sheer in and of itself, is that most poskim assume that sirus isha, castrating a woman, sterilizing a woman, is an issur d'Rabbanan, not an issur d'Oraisa. For a man, it's an issur d'Oraisa, say a vasectomy. But for a woman, according to most shitas, it's an issur d'Rabbanan. There is a famous shita of the Vilna Gaon that disagrees. The Gra holds that sirus isha is an issur d'Oraisa. And therefore, we generally assume that a tubal ligation is usher, is forbidden, unless there are circumstances that of PUAH nefesh. So there are cases where a woman is told that you must not get pregnant, because if you do get pregnant, your life is in danger, and for whatever reason, this form of contraception and that form of contraception are not available, they don't work. Often the woman can't take any of the hormones, and the spermicide is not effective enough, and whatever it is, her body rejects the IUDs, so she's exhausted all of her options. And this is kind of our last option. Our last option is the tubal ligation or a condom, and then we have to weigh which is better. So under those circumstances, when her getting pregnant is a sakana, a legitimate sakana to her health, to her life, and there are no other alternate options, so then we would then begin to contemplate and to discuss the tubal ligation, but without that, we stay away.
The next three we could want to put in a grouping together: removal of the fallopian tubes, removal of the ovaries, and removal of the entire uterus. So one of the things that I encounter often are patients who carry a BRCA abnormal gene for breast cancer, which makes them highly likely not only to get breast cancer, but likely to get ovarian and fallopian tube cancer. And ovarian and fallopian tube cancer, which now go together, unfortunately, 75% of people who get that cancer will not survive their cancer. So one of the things that we commonly do when we identify their chance is so much higher, is 10 and 20 and 30 times higher than the regular, is after childbearing is done, we remove the tube, the fallopian tube, and the ovaries, both of them, to decrease the chance of them getting that cancer. To just continue the conversation, a lot of times physicians and or the patient will say, while you were there, although it's not part of the syndrome, could you remove the uterus as well? Because as long as you're there, could you just take everything out? And a lot of physicians, there are some reasons to do it, but in general, the surgery is to remove the fallopian tubes and the ovaries. Okay, so my question is twofold. One is hearing, and I already know the answer, is we're taking out healthy tissue, right? We want to take that out before cancer strikes so that we are removing and sterilizing the woman, right? Taking out her ovaries and her tubes. And then is there a different issue in taking out an organ that's healthy, that's not part of the syndrome along the way when you take everything out as a unit? So a twofold question.
You said you know the answer. PUAH nefesh trumps. So PUAH nefesh trumps taking whatever you need to take out. I once asked the Shiloh to Rabbi David Cohen, this exact Shiloh, about the second Shiloh, about taking the uterus out when they're already in, taking out the fallopian tubes or taking out the ovaries. That was her case. Rabbi David said that if there's any, Rabbi David said that if there's any concern that the uterus could become cancerous, could develop something, could pose even the slightest sakana, then you can take it out. Then you take it out. What are the chances that leaving the uterus in would contribute or would have a negative impact with the future cancer development?
Well, it's the same as for every woman, specifically in this one syndrome, BRCA.
Yeah.
It is not increased. However, when you take out the tubes and ovaries, and you're taking them out when the patient's 40 years old, you will give them hormonal replacement. And that hormonal replacement will have an effect, might have an effect on the uterus and cause the uterus to turn cancerous. So there is that, and that's one of the reasons why people want to take it out, so they could receive a specific hormonal replacement that will not cause an effect.
If the concern is a cancerous one, the concern is they want to do their utmost to protect themselves and position themselves in the best, most healthy, the healthy position, then Rabbi David told me that he didn't think it was a problem. He could remove the uterus. I do want to remind people that you can have children as long as you have your uterus. You can have your own children. You can do IVF as long as you froze eggs before you took out those ovaries. Couples can have children in the future even without their fallopian tubes, even without their ovaries. So a woman could take out the ovaries and take out the fallopian tubes to prevent the cancer risk. And then should they want children in the future, they can do an embryo transfer, have that baby even without the ovaries and the fallopian tubes. So that would be a reason to keep the uterus in.
So I was called by a fertility doctor that he was going to do an embryo transfer on a patient and he found out that she was BRCA positive and needed me emergently to remove the tubes and ovaries before he put the embryo in. So actually I called the hospital and we were able to get operating room time. I took it out. I took out her tubes and ovaries and I asked her, like, what's your plan? She goes, well, I hope to see you in 2 weeks because I'm going to have my embryo transfer. And not only did she come back and have one baby without tubes and ovaries, she came back and had a second baby after that.
Wow. Yeah. So definitely something to keep in mind.
Interesting. With that, we've talked about most of the procedures, the most common procedures that I do in my office and in the operating room. So I've finished what I've liked to discuss. Any additional comments?
I do want to, in the chat, I see that someone said not to forget to discuss the balloon. Under what circumstances are balloons used to dilate the cervix to penetrate into the uterus to gain entry to the uterus? And would that ever cause a psichas hakever question?
So I don't know specifically what they're talking about. The only procedure that I use a balloon for is a water sonogram, where I'm doing a sonogram. I put a small catheter into the uterus, and through that catheter, the walls of the uterus are touching each other. So I want to separate them with water to see what's inside the cavity. So at the very end of that, it's a very tiny balloon. There is no way that it gets past 19 millimeters, but it acts as a plug. So when the water comes in, it just doesn't, come right out, and it holds actually the catheter in place. So in thinking of the things to talk about tonight, it really didn't cross my mind to talk specifically about a balloon unless they're referring to something else.
Okay, I see there were a lot of questions about endometrial biopsies, HSGs, all of those things, as we've discussed, even the saline sonogram procedure, all of those things we've discussed, the instruments that are used for all of those are smaller than 19 millimeters. Even if there is bleeding from the uterus, as long as it's really just local bleeding from a specific trauma, then most post-kim are lenient and assume that does not render a woman a niddah. Again, if that turns into a flow, that's something else that has to be considered. But the procedure itself should not render a woman a niddah, should not put her into niddah if she was not already. I think does a balloon catheter for induction cause a niddah?
That's a whole, okay, so that's what they were referring to. Okay, so that balloon is definitely bigger than 19 millimeters. Often, and I use it most commonly in a patient who had a previous cesarean section where I don't want to use medications to put them into labor. And the balloon gets inserted into and through the cervix in order to sort of put pressure on the cervix, and from that releases the body's sort of natural chemicals to help start contractions and so on. I would imagine that would stretch the cervix, and it does greater than 19 millimeters, even if you don't see any blood.
Yep. Yep.
So at the time, so that, that's at the time that it's placed, if it makes them a niddah, that could be hours and hours and hours before really, labor kicks in at all. It's a mechanical.
Yeah, it definitely does sound like a psichas hakever issue. Absolutely.
So I thank them.
Is everything discussed the same for non-Jewish doctors, or is Dr. Herman specifically careful about these procedures? I guess the question is that, let's say you don't have this chus of seeing a from OBGYN. So you have, let's say, a non-Jewish doctor. I'm sure there are wonderful non-Jewish doctors out there.
Right.
Are you allowed to rely on them when they say that this, let's say this bleeding is from the cervix, or this tool is less, its instrument is less than 19 millimeters. The truth is, it's discussed. It's discussed in Hilchos Niddah. It's actually discussed in that sugya about Roa Dam Machmas Tashmish, when if a woman sees blood 3 times after relations, so then the Gemara talks about a case, some type of internal check to try to identify where the blood is coming from, whether it's a makkah or whether it's indeed coming from the uterus. And there, the Shulchan Aruch has a very large, lengthy discussion in the later Day Achronim about the status of a non-Jewish doctor or a non-from doctor. Are we allowed to believe him? We generally assume lahalacha that if a doctor is, if you phrase the question in the right way, this is true of Niddah, it's true of Kashrus, it's true in every area of halacha. If you phrase the question in the right way, where you don't tell the doctor that I need this answer and I need you to give me the right answer, so this is why I'm asking you, right? But you ask them in a little bit of a roundabout way. If you say, for religious purposes, I want to know what size, what is the measurements of this tool? They're never going to know what's too big, what's too small, what you're looking for, what you're not looking for. If you phrase it, this was smaller than 19 millimeters, right? Like, because my religion won't allow for more than 19, so this was smaller, right? If you phrase it in that way, then a non-Jewish doctor might not be believed to say yes, because he obviously wants to make his patient happy. And it's clear that the patient fed him the right answer. So when you're dealing with a non-Jewish doctor, you should be careful to phrase the question in a very parav way, in a very professional way, kind of a matter of fact, and allow the doctor to answer the question. And based on those answers, you can report back to your Rav and work through the details to figure out the final psak.